Good evening. My name is Doug Hanto, and I'm the co-chair of the Surgical Ethics Working Group in the Center for Bioethics at Harvard Medical School in Boston, along with my co-chair, Dr. Teresa Williamson, who is a neurosurgeon at Massachusetts General Hospital. On behalf of the Surgical Ethics Working Group, I would like to welcome everyone to our second annual Harvard Surgical Ethics Conference. Our second session this evening is Challenges to the Patient-Surgeon Relationship. We will host two more sessions on September 19th and 26th. Over 550 individuals have registered for the conference from around the world, and we would like to thank you for getting up early, staying up late, and taking time off from work or leisure to join us this evening. I believe we have an exciting hour and a half ahead of us. It is my pleasure to introduce this evening's moderator, Dr. Jonathan Marin. Dr. Marin is a pediatric oncologist, health services researcher, and educator at Boston Children's Hospital and the Dana-Farber Cancer Institute. He is currently an attending physician in pediatric hematology and oncology and a clinical ethicist at Boston Children's and an instructor of pediatrics at Harvard Medical School. He is also director of clinical ethics at the Center for Bioethics at Harvard Medical School. Dr. Marin's research focuses on the intersection of ethics and decision-making with a particular interest in pediatric genomic sequencing. His bioethical areas of interest include pediatric ethics, ethical issues in genomics, informed consent, healthcare disparities, and research ethics. He will be introducing this evening's speakers and moderating our panel discussion. Thank you, Dr. Marin.
Thank you, Dr. Hanto. So today, following last week's spectacular talks related to xenotransplantation, we will have 4 specific talks examining challenges to the patient-surgeon relationship. We're lucky to have some really incredibly thoughtful and accomplished individuals joining us tonight, both you all as attendees and our panelists who are speaking. So thanks to all of you again for joining. Thanks to Drs. Hanto and Williamson, and to the Harvard Surgical Ethics Working Group for inviting me to moderate this session. And thanks, of course, to the Harvard Medical School Center for Bioethics for sponsoring this wonderful conference. To those of you joining us for the first time, welcome. And to those of us who are with us, those of you who were with us last week, welcome back. So as we get started, let me first orient you to our plan for the next 90 minutes or so. I will introduce each of our speakers a little bit more extensively before their talk. Our first presentation will be from Dr. Richard White, who will provide us with a brief introduction to the patient-surgeon relationship. Next, we'll hear from Dr. Alicia Elmore. Dr. Elmore will present lack of a diverse workforce. You'll then be stuck with me for a presentation entitled Duties and Boundaries: What are the limits of clinicians' obligations to their patients? And finally, our presentations will conclude with Dr. Louise King, who will speak about the impact of the Dobbs decision on the patient-physician relationship. After these talks have completed, we should have quite a bit of time for questions and discussion. So as Dr. Hanto was saying, please feel free to enter questions into the Q&A box at any points during any of the presentations. We'll keep an eye on the questions throughout and try to get to as many as we can. Our first speaker tonight is Dr. Richard White. Dr. White is a cardiothoracic surgeon and the vice chair of surgery at Beth Israel Deaconess Medical Center here in Boston, where he's also the vice chair of quality, safety, and clinical affairs, also at Beth Israel, and professor of surgery at Harvard Medical School. He received his MD from the University of Pittsburgh and an MBA from Wharton at the University of Pennsylvania. Dr. White is interested in bioethical issues pertaining to the field of surgery, particularly his special field of cardiothoracic surgery. Dr. White will give an introduction to today's session, brief introduction to the patient-surgeon relationship. Dr. White?
John, thanks very much for that kind introduction. Let me just quickly put my share my screen up here. I got a couple of slides to show. Hope people can see that. Anyway, just want to say good evening to everybody, all of the audience. First, I'd like to thank you for attending the second session of the 2023 Harvard Surgical Ethics Conference. Today, as you heard, we're going to discuss challenges to the patient-surgeon relationship with 3 focused presentations. My job being to create some framework for analyzing the issues that you'll be hearing about. As such, I'd like to suggest 2 frameworks that can be used to view or analyze the physician-surgeon or physician-patient relationship. The first of these frameworks was described in Ezekiel and Linda Emanuel's classic paper of 1992 from JAMA. It was entitled 4 Models of the Physician-Patient Relationship. And in this paper, Drs. Emanuel focus on medical decision-making and offer 4 models for the physician-patient relationship. As you can see here, these include a paternalistic model, an informative model, an interpretive model, and the deliberative model. Well, I won't go into a great deal of detail on each of these. I'd characterize the paternalistic model as involving the physician using his or her specialized knowledge or skill to determine what is best for the patient. The physician provides information authoritatively and sometimes selectively, such that it encourages the patient to pursue the recommended treatment. The physician then carries out the plan. What is best for the patient is essentially determined by the physician. In the informative model, the physician provides the patient with all relative information or facts, and the patient decides what to do given his or her values. It's a very consumer-based model where the physician provides information but doesn't really insert his or her own values into the decision-making process. Except for the implementation, the physician is primarily a purveyor of technical information. In the third or interpretive model, the physician's job is to elicit the patient's values in addition to providing information and to assist the patient in choosing an appropriate course of treatment that is in accordance with those perceived values. In this model, the physician more or less serves as a counselor to the patient. Finally, in the deliberative model, Emanuel suggests that the physician assume the role of teacher or friend, providing knowledge and suggesting an appropriate course of action. In this setting, the physician offers not only what the patient could do, but offers an opinion as to what he or she should do. While Emanuel posits this as a separate 4th model, my sense is that this is really a case-appropriate blend of the other 3 models, each of which has a role in clinical practice. I think that it's important to realize that these models are just that. They are models, and they're tools to examine reality, and they do not fully reflect the complexities of the real world, and that any actual physician-patient interaction may blend these models to a form that is appropriate for the situation. Finally, I would contrast the above with the description of the physician-patient relationship as described by Beecham and Childress in their classic text, Principles of Biomedical Ethics. In this text, which is now in its 8th edition, the authors use the concepts of veracity, privacy, confidentiality, and fidelity as principles underlying the physician-patient relationship. These would be rules of behavior, if you will, with respect to how a physician or surgeon should interact with his or her patient. In this framework, the rules of engagement relate to how physicians interact with patients and are derived, not surprisingly, from the author's 4 classic ethical principles of autonomy, beneficence, non-maleficence, and justice. Again, without going into a great deal of detail, veracity refers to truth-telling and the fact that trust needs to be a cornerstone in the relationship between the surgeon and the patient. Privacy and confidentiality, while clearly related, are different in that privacy refers to the patient's control over access to him or herself. Now, this can refer to physical privacy, informational privacy, or any other types of access. Confidentiality, on the other hand, refers to disclosure or lack thereof of information about a patient when the patient does not want that disclosed. Finally, there's the issue of fidelity, or how does the physician deal with obligations to the patient? While fidelity may seem like a simple concept, such as put the patient first, it's probably oversimplistic to think that the relationship between the patient and his physician exists in a vacuum, devoid of other obligations on the parts of either the patient or the physician. Obligations of the physician, such as obligations to himself or his family, his other patients, his employer, colleagues, or society in general. So while either of these frameworks can be used to examine some of the modern stresses on the physician-patient relationship, like many moral or ethical problems, no single model or construct is ideal. As you hear the following talks, please keep these frameworks in mind, and I will look forward to the subsequent discussion. Thank you very much.
Thank you so much, Dr. White. That was a spectacular introduction that I think will set our attendees up for some of the really thoughtful pieces that will be added by our next couple of speakers. That said, without further ado, I am delighted to introduce our second speaker for this evening, Dr. Alicia Elmore. Dr. Elmore is a breast surgeon specializing in both benign and malignant breast disease in her clinical practice at the Hospital of the University of Pennsylvania and Penn Presbyterian Medical Center, both in Philadelphia. Her academic rank is as assistant professor of surgery at the University of Pennsylvania. Dr. Elmore went to medical school at Washington University in St. Louis, where she also received, alongside her clinical training, a master's in population health sciences. Dr. Elmore has various research interests related to the promotion of evidence-based, equitable, and high-quality healthcare for all patients, including focusing on patient-provider communication, mistrust, and decision regret, racial and gender disparities in breast cancer outcomes, and leveraging technology to improve communication and disparities in cancer care and outcomes. Please join me in welcoming Dr. Elmore, who will be teaching to us today about lack of a diverse workforce.
Hi, everyone. It's an absolute pleasure to join you tonight and to be a part of such a wonderful and esteemed panel. And so I'm going to spend the next 15 minutes or so talking to you about lack of a diverse workforce and implications for the patient-surgeon relationship. We're going to start out by talking about what diversity is, why it matters, and if diversity is truly enough. And so to get started, I began by doing basically what every good geriatric millennial does. And I turned to Google and said, what does Google say about workforce diversity? And so what came up was a writer, Elia Cooks Campbell, who described 4 types of diversity. And so the first type of diversity was internal diversity. And so that's what we traditionally think as traits of an individual, such as biological sex, race, ethnicity, sexual preference. But then there's also external diversity, which are modifiable characteristics based on your identity or lived experience, such as your socioeconomic status, family composition, geographic location. There's also organizational diversity, or the composition of the institutions with which we work and with which patients seek care, such as an individual's role, the experience, the length of time that they've been there. And then there's worldview diversity, which are differences in how we view the world, what our personal preferences are, what our political preferences are, and all of those inform diversity. And I include this for an important reason, because I'm going to distill over the next 15 minutes workplace diversity into a couple key categories. But I want to make it clear that this is not exhaustive, and diversity in all forms impacts the experience of our patients and the way that we interact with our patients and the relationships we form. So over the rest of this talk, I'm largely going to focus on racial and ethnicity and gender identity. And so I think first it's important to think about why diversity matters, why it matters to healthcare systems, and why it matters to our patients, because that impacts the relationship between patients and providers. And so let's start with a case. So I'm a breast surgical oncologist by training, and many of you are in healthcare, and I think it's interesting to approach it from this standpoint. So I have a 26-year-old patient that walks into my office who's 17 weeks pregnant and is diagnosed with a locally advanced breast cancer. And so when this patient walks into the office, there's a lot of issues at play, right? The first thing we think is, oh man, this is a really tough situation. But then we think, okay, I'm a surgeon, and looking at it from that perspective, one of my first thoughts is going to be, let me discuss this with other surgeons. My next thought might be, why don't I talk to medical oncologists who have a slightly different perspective than I do? My next thought is likely going to be, why don't I talk to the OBGYN that's taking care of this patient because she's pregnant? And then a final thought, or not a final thought, but an additional thought is, why don't I take this to tumor board and discuss this with experts across multiple different specialties? And I tell you this to highlight that we in medicine have acknowledged the benefit of diverse perspectives and realize that that enriches the outcomes for our patients. But yet still, racial and ethnic diversity has been limited within healthcare. And so why does diversity matter? And so, I really want to highlight the idea of groupthink. And so groupthink was coined by Irving Lannis in 1971. And to quote him directly, he said, "I use the term groupthink as a quick and easy way to refer to the mode of thinking that persons engage in when concurrence seeking becomes so dominant in a cohesive in-group that it tends to override realistic appraisal of alternate courses of action." And so when we have a workforce that is not homogeneous, we are not as innovative in how we approach our patient care, and that impacts the care experience for our patients. And to be honest, in healthcare, we are really behind when it comes to thinking about diversity. And right now we're in this phase where we're kind of describing the state of diversity. And, in terms of looking at outcomes, the data is actually pretty limited. And so I think it's important to briefly highlight some of the findings that have existed in the business literature, which are far ahead of where we are now. And so one of my favorite quotes born from the literature is from Khalil Smith, who's VP of DEI at a big cloud-based technology company. And he said, diverse teams consistently outperform homogeneous ones, especially on tasks that are creative, nonlinear, or complex. And that basically describes everything that we do in medicine. And so just to quickly touch on a few studies in business that have highlighted why diversity is important. McKinsey and Company actually looked at 366 public companies and found that more diversity produced a superior financial return. So basically, the 25% most diverse companies generated 53% more return on equity. And so this isn't to make it about money, but what it highlights is the fact that the systems that our patients are treated in are better if there's more diversity. In another study, there was a mock trial where deliberations were conducted with a jury that was homogeneous or a jury that was diverse. And so what that highlighted, in the juries that were diverse, there were less factual errors, more deliberation with juries that were diverse. And so we can't help but ignore, right, that being factually accurate and being thoughtful about patient care is important. And then final study in the business world demonstrated that gender diverse teams outperform gender concordant teams in terms of sales and profit. And so I'm sure you're now thinking, okay, Leisha, but what about medicine? And so when we think about medicine, there's really a paucity of data on diversity in medical outcomes. And so I'm going to highlight a few of the key findings that exist in the literature as it stands. So Gomez and Burnett did a big review in 2019, and they identified only 16 sentinel studies that looked at the impact of diversity on outcomes. And so when we look at these kind of key studies, there are really a few categories that are critical for patient outcomes and the impact of a diverse workforce. In terms of outcomes, what we have seen is that patients treated at institutions with a higher degree of diversity or with providers who are racially and ethnic diverse have more accurate diagnoses, higher patient satisfaction, and greater compliance. And this was from a meta-analysis of 25 studies. What we have also seen is concordance between physician and patient can impact patient outcomes. And so if we don't have a diverse workforce, how can we have concordance between our patients and providers? And so while the data are mixed, there is evidence that there's improved adherence. Patients are more likely to fill recommended prescriptions. Patients report improved communication when there's concordance between patient and provider. And then I'd be remiss not to mention that there are benefits to the organizations the two diverse organizations. And so there's been shown to have higher innovation and higher reputation in places that have racial and gender diversity within the institution. And so I figured someone was going to ask me about this because we've all seen it. It's been sent to me many, many times. And so I thought it was important to mention. So in a recent publication in JAMA Surgery, there was a study on gender diversity and surgical outcomes. And this was a retrospective cohort study of 1 million patients treated in Canada over a 12-year period. And the conclusions demonstrated that female surgeons had a lower 90-day and 1-year rate of adverse postoperative outcomes compared to male surgeons. And I do want to comment that there was a low overall adverse event rate. But what was striking from the study is that the lowest rates were seen among female patients treated by female surgeons, though this finding was consistent within male patients. But there are certain limitations of this data. So there's no data on patient selection or complexity or nuance on characteristics of the surgeon. And so I'm not telling you this to say that women are better. That's not the goal that I want you to conclude. But what I want to highlight is that gender diversity in surgery, in what was previously a male-dominated field, is important for our patients. And so when we look at how things have changed over time, so, screen left, we can see that gender diversity, and this is from 2014 to 2018, physicians were about 40% female, and there's actually a little bit more parity now than existed at the time of this study. So there has been progress with gender diversity, but there are still disparities both at the subspecialty level and in surgical leadership. But when you look to the right, what you can see is the triangles are white surgeons, the circles are African-American surgeons. So I want to kind of highlight those groups. And what you can see is that really the needle has not moved for racial and ethnic diversity in surgeons for like over 2 decades. And so what's our big why? Why does diversity matter? Why am I here talking to you about this? And so, all of us hope to aspire towards equity and justice. So, at all the institutions I'm sure that you work, in all walks of life, many of us hear now that diversity, equity, inclusion is king, and that's our goal. And so a diverse workforce matters to achieve that goal. And the reality is much of the work towards diversity, equity, inclusion, and justice is led by racial and ethnic minorities. So if we don't have a diverse workforce, are we really going to be able to effectively move the needle? And so what's our other big why? Our other big why is that diversity in medicine matters to patient care and outcomes. So racially and ethnic diverse patients have inferior health outcomes, are less likely to receive standard of care treatment. And to advance health equity, we need more efficient, compassionate, and comprehensive systems of care for all patients. And what we know is that providers who are underrepresented in medicine are more likely to provide care to minority and medically underserved patients. Minority patients endorse higher levels of comfort with underrepresented in medicine providers, and minority patients are more likely to participate in clinical trials if a underrepresented in medicine physician is on the investigative team. Simply put, patients want to see individuals in healthcare that look like them. And so why is this the case? Why do these differences exist? And so I want to take a second to comment on medical mistrust. And so many of us, what I hear quoted so often is, this is based on our history, right? This is from a historical perspective. Many of us have heard of the Tuskegee study, which, just to briefly mention, in 1932, 600 Black men were enrolled, for almost 400 with syphilis. And when penicillin became widely available 11 years later, the participants in the study weren't offered that treatment. That's indisputably unethical. And then we have Henrietta Lacks, whose cells from her cervical cancer biopsy were used to create the cell line we know as HeLa cells, which has been widely used in medical research. Consent wasn't required at the time, but neither patient nor her family were aware of the use of these cells. And when the cell cultures became contaminated, researchers reached out to the family to get blood, and medical records of the family were published without their consent. And so many people will cite this as the basis of medical mistrust. And while that does serve as the foundation for many people, it's not just our history. there are implications of medical mistrust that are really important, and they exist today. And so, in a study of 277 Black participants, 101 white participants, only 2/5 were actually familiar with the Tuskegee study, and there was no association between knowledge and level of mistrust. But there were significant racial differences in level of mistrust, with Black patients reporting significantly higher levels of medical mistrust. And bias remains pervasive in care today. Black patients are less likely than white patients to receive analgesia for acute pain. So, as surgeons, right, if our patients feel like they're not going to be adequately treated for their pain, are they going to receive the therapies that we offer to them? Are they going to feel comfortable in our care? There are also differential reports of communication quality based on patient race and ethnicity. And then, as Dr. White mentioned in his intro, all these interactions between patients and providers are not in a vacuum, and experiences outside of the hospital and experiences in an individual's life inform the interactions between patients and providers. And so finally, the question is diversity truly enough? And I actually argue that diversity should not be the penultimate goal. So there's a quote that I really like by Verna Myers that says, "Diversity is being invited to the party, inclusion is being asked to dance." And so inclusion is creating an environment where people feel seen, heard, supported, and safe. So for our patients and for the individuals that work in an organization, we really want to foster a sense of belonging and a sense of respect. And so what are the barriers to inclusivity in the workforce? One of the biggest barriers to inclusivity is implicit bias. Explicit bias occurs when individuals are aware of their prejudice or preferences towards a group, but implicit bias is that unconscious bias that drives our behavior. It's that rapid, instinctive, usually involved unconscious stereotyping that leads to discriminatory behavior. And so what's that behavior? It often results in macroaggressions, but more commonly microaggressions towards our patients, and undermines our relationships with them. So macroaggressions we think of as that overt aggression to an individual, and that's not the most common thing experienced by our patients. Microaggression was actually coined by a Harvard psychiatrist, Chester Pierce, in 1970, and referred to the minor but damaging humiliation experienced by African Americans, and has now extended broadly beyond that to include abuse, devaluation, and disrespect of individuals. It's much more subtle. I like to think of it as death by 1,000 cuts. It can even be body language. It can be tone of voice. So it's the verbal and nonverbal indignities that we inflict upon patients. And so what are the results of this? The end result impacts both the diversity in our workforce, the quality of the care the patients receive, and the interaction between the two. For providers, it looks like depression and anxiety. It looks like imposter syndrome, burnout, lack of belonging that leads to the attrition and undermines the goal of a diverse workforce. For our patients, it looks like isolation and judgment, mistrust, fear, poor adherence to the prescribed treatment plan, and ultimately worse outcomes. And so I will leave you with the fact that a diverse workforce is not the solution, but it's important to amass a critical mass of individuals who are diverse. And it's important because it is a key to creating a more equitable patient experience and optimizing patient outcomes, leading to our goal of equity, justice, and inclusion within healthcare systems. Thank you.
Thank you so much, Dr. Elmore. That was spectacular, and lots of food for thoughts that I'm sure we'll delve into in just a little bit during our discussion portion today. I'll be our next speaker. I certainly am not going to go into detail in introducing myself. That would be both odd and uncomfortable, and also because Dr. Hanto already provided a far too kind introduction of me at the beginning of today's session. So let me get started, and I will share my slides. All right, so thank you again for inviting me to speak. I'll be discussing here duties and boundaries. What are the limits of clinicians' obligations to their patients? I've spoken about this topic a couple of times before, but it's largely been with colleagues in oncology. So I'm really excited to hearing the perspectives and feedback from you, my colleagues in surgery. Briefly, a couple of quick financial disclosures. None of these are germane to what I'll be discussing today, so I won't read through them individually. Notably, I'm not going to reference any particular drugs, products, or devices, either on or off label. But I will acknowledge a couple of other disclosures, which are probably even of greater significance than the financial ones. So first and foremost, I'm not a surgeon. I'm thrilled to be joining this group today and to get to work with surgeons every day. But I want to make sure that I put my cards out on the table. I am a pediatric oncologist, a bioethicist, and an educator. That background certainly informs my thinking and a lot of what I'll be discussing with you here today. As I mentioned, I've spoken about this issue with oncologists, and I'm excited to see, do we think about it differently amongst surgeons than we might in other settings with other types of clinicians. Learning science teaches us that we learn best what we hear first. So I'm going to start off with a couple of take-home points. So one, conceptualizations of boundaries have evolved over time, but they're not something that's truly new in healthcare or in surgery specifically. Second, setting boundaries can be ethically acceptable and may actually be something that we consider to be ethically preferable. We just have to go about it thoughtfully. We have to go about it carefully. And on the flip side, having no boundaries can actually be quite ethically and clinically problematic. And finally, ethical boundary setting is not easy. It requires introspection, it requires being intentional, and it requires recognition that setting boundaries has its inevitable trade-offs. And it requires sometimes saying no to FOSNO. If you don't recognize what FOSNO is, you are probably not the only one. That is something that I'll come to in just a couple of moments. So let that be a little teaser for you. But before I continue, let's start with a case to get us in the groove. Let's imagine a surgeon named Dr. S. Dr. S is a few years into their practice as a general surgeon at an academic hospital, and is really starting to get in the groove and progress in their career, both as a surgeon and as an academic researcher. They have a busy surgical practice, a growing research portfolio. They're married, they have 2 young children at home. And perhaps not surprisingly, they're struggling a bit to balance home and work life and to set and ultimately to keep boundaries. I'm guessing that this is not an entirely unfamiliar scenario to many people who are joining us today. So continuing a little bit, Dr. S is having particular challenges with one patient in particular. This patient found Dr. S's email address online. Most of us are not too difficult to find online. And this patient sends Dr. S frequent emails to their direct email, despite having received very clear instructions to use the on-call paging system for emergency questions, or the messaging system through the electronic health record for things that are non-urgent or non-emergent. Now, admittedly, Dr. S cares deeply for this patient, cares deeply about this patient's well-being, but this behavior, despite numerous requests and even pleading to not act in the way that this patient is acting, is really causing Dr. S quite significant distress. It's affecting their care of their other patients, it's affecting their academic work, it's even affecting Dr. S's home life. Dr. S has talked about this with a number of their colleagues, and one colleague in particular tells them that they should fire the patient. But Dr. S is unsure, one, how to go about this, but even if that's an appropriate thing to do. So I pose this question to you. Could it be ethically acceptable for Dr. S to fire this patient? All right, and I'm curious to see what people say. So you can answer this question a couple of ways. If there's a QR code up here, you can snap the QR code and that will take you to this site. The website that you can vote at is also at the top, polev.com/jmarin. And I put it into the chat so that everybody can have that as well. So give people a couple of moments. The results are starting to come in. As people are voting, I'll acknowledge that when I asked this most recently at a big meeting of oncologists, it was in a live session, and I received laughter, and very few people raised their hand when I said, raise your hand if you think it could be ethically permissible to fire this patient. All right, so let's see what people say. All right, so a relatively even split, but perhaps a slight majority leaning towards that it could be ethically permissible for Dr. S to fire this patient. So that's interesting. That's we as of right now have how many people we responded? Quite a number. Great. All right, let's continue. All right, so with that setting the stage, I'm talking today about boundaries. So boundaries both in surgery and in healthcare more generally, like many things, can be thought of as a spectrum. So on one end, we have a situation in which we have too few boundaries, and the other too many boundaries. In some ways, I think you can kind of think of this a little bit like Goldilocks. We're ideally looking for that perfect sweet spot in the middle, where the amount of boundaries are just right. With too few boundaries, we run the risk of such problems as conflicts of interest and conflicts of commitment. We certainly run into issues or potential for loss of balance, being over-engaged with our work and potentially under-engaged with other aspects of our life. There certainly are emerging data that all of this ultimately downstream can lead to decreased satisfaction in our work and decreased quality of patient care. If the pendulum swings and we have too many boundaries, we may encounter such negative outcomes as insufficient connection with our patients and our work, decreasing the human element and disengagement with what we're doing and and both our patients and other types of work. And ultimately, this again can lead to the downstream consequences of decreased satisfaction and decreased quality in our patient care. So again, if we're too far to one end of the spectrum in either direction, we could ultimately have similar negative outcomes. Importantly, boundaries aren't new. This is not a new topic, either in surgery or healthcare more generally. There have been many publications, many from upwards of 30 years ago, that address the topic of boundaries. A couple here for people who would be interested in looking these up later: physician-patient boundaries, professionalism training using video vignettes, necessary boundary crossing in pediatrics, professional boundaries in the physician-patient relationship, and even can one be a good doctor and have a sexual relationship with one's patient? And yes, this final one really is a real manuscript that was published in the medical literature, and that question was not being posed rhetorically. I'll let you all, on your own time, read this more and see what they had to say about it. In the past, most would argue that we probably had too few boundaries in healthcare. But discussions about boundaries differed in focus and largely compared to many of the discussions that we're having today. Then, just as you could see from the titles of those couple of papers that I showed screenshots of, we largely referred to things like blurred lines, whether it's blurred lines with our relationship with patients, blurred lines with companies, things like that. Similarly, made reference to limited guidance regarding conflicts of interest and conflicts of commitment. And as a result, there are compelling data that demonstrate that these inadequate boundaries over time led to a decrease in trust in clinicians and possibly some negative impact on patient outcomes, though that's a much harder metric to track and to quantify. Certainly, there's at the very least, in the setting of having too few boundaries like these, a risk of decreased well-being for clinicians and increased risk of burnout. Today, we likely still fall on this too few boundaries end of the spectrum, but our conceptualization of boundaries and the primary focus in our thinking and talking about them has largely changed. Certainly, we still talk about those same kind of boundaries, but the majority of discussions in the literature and in academic meetings and otherwise, as we're largely referring to things like limitations in our work-life balance, being always connected, whether it's the devices, all of which we are certainly on at least one, if not multiple devices all right now. Talking about lack of boundaries with regard to the increase in complexity, the increase of need, the increase of time that patients today are requiring out of clinicians. But again, coming back to the same downstream negative consequences of decreased well-being and increased possibility for burnout. So this is part of an ethics conference, and so we'd be remiss not to ask about some of these ethics questions head on. So I hopefully next we'll be able to describe for you what the ethical low bar is for boundary setting with patients. One could argue that the low bar can be conceptualized as what we are ethically obligated to do. Importantly, that's very different than what is best or what we might prefer to do in a vacuum or even in a perfect scenario. I think this applies both when we're talking about boundary setting and also in the more familiar setting of clinical practice. In clinical practice, I'm guessing that most would agree that we aren't always expected to choose the single best option. Much more commonly, there are a variety of options that all fall above a particular threshold of acceptability. And what we aim to do as clinicians is choose one of these various ethically acceptable options above that level, above that low bar. In surgery, for instance, you could imagine a surgery that has a high likelihood of high benefit, but alongside that, a significant risk of toxicity or complication. And then there's a second surgery that has a less toxic option, but is less likelihood of a home run. Either of these two options might both be considered to be ethically acceptable. And if we provide patient consent and talk about the ins and outs and risks and benefits and various different options that could go along with both of these two options, it seems ethically permissible that one could proceed with either of these two, depending on what the patient chooses. When we're setting boundaries, we aren't the same kind of logic applies. We also are not expected to do what might be the absolute best for every single patient, or even the absolute best thing for our own professional lives. Instead, we aim for a personally defined balance as long as it's falling again above this ethical low bar. And so how do we define this low bar? In most cases, when we're talking about a patient-specific issue, patient abandonment is what falls below that low bar. So non-abandonment in some ways is the bar. What is patient abandonment? Ultimately, it's firing a patient, but without providing adequate time and availability for them to find an alternate provider. So ethically and legally, there is an obligation to provide emergency care stabilization. EMTALA is the legal grounding for this. And depending on circumstances, we may also be obligated to facilitate transfer of care for patients that we intend to stop taking care of or quote unquote fire. Admittedly, there is a very negative connotation to firing. So I'm using that kind of common vernacular here, recognizing that it is a little bit glib. But as we're talking about it, it's important to recognize, is that a term that you would ever consider using with a patient, or something that we might refer to as an entity, though not individually with patients themselves? Importantly, this idea of patient non-abandonment as being an ethical low bar is a pretty consistent one. Most modern Western medical ethical guidelines may provide at least some reference to this. I've provided here a reference to the AMA, or American Medical Association Code of Medical Ethics, which makes very clear statements about this. Here in the United States, state and federal laws often quite frequently make reference to this. And it's often, and patient non-abandonment is often referenced also in hospital codes of conduct and patient bills of rights. I imagine that for many of us, many of our hospitals have commentaries or statements about this. So how do we find the ethical sweet spot when it comes to boundaries? Remember that, as I mentioned before, this is a little bit of a Goldilocks situation where we're trying to find the right balance, where we neither have too few nor too many boundaries. Ideally, the balance allows for providing what ultimately is high quality care while still setting boundaries that are right for you, and involves recognizing and choosing when to connect and when to disconnect, while at the same time recognizing that inevitably there will be trade-offs. If you're setting boundaries and not working 24/7 and not making yourself available to patients via your cell phone, by email, by text, by the EHR, by a million different ways, there are drawbacks to that. And that's not to say that you shouldn't do so, but you need to be aware of what the trade-offs will be. And importantly, while I've been largely referring to clinical care here, this balancing and trying to find the sweet spot also applies to our non-clinical work, whether that's research, teaching, whatever else it might be. So setting boundaries can ethically include a variety of things. It certainly can include discontinuing relationships with patients, particularly if those patients are being abusive, if they're demanding non-recommended therapies, if they don't respect the boundaries that an individual clinician has set, if they're expecting 24/7 availability, a variety of different things. Setting boundaries may ethically include saying no, whether that's to patients in our professional lives, saying no to projects or collaborations, to patient requests, to colleagues, to superiors, to opportunities. I put quotations around opportunities here because I think many people here have probably been invited to have a quote unquote opportunity that seemed like it was an opportunity for somebody else and not so much an opportunity for us. But certainly setting boundaries may ethically include each of these different things. When I first began thinking about these questions with colleagues, we spun off the idea of FOMO, or fear of missing out, which is something most people are familiar with, I think. And building off of that, we created the acronym FOSNO, fear of saying no. So the citation for the paper that we describe that concept a little bit further is at the bottom of the slide, and the QR code here can link you directly to that, to the full text of that. You'll just have to click to skip the advertisement. Sorry about that. I'll have that QR code also in my last couple of slides if you're interested in checking it out. But perhaps most importantly, I'm a pediatrician, so I'm contractually obligated to include a cartoon character in every talk I give. So make sure you listen to Mickey Mouse and say no to FOSNO, fear of saying no. But importantly here, the devil's in the details. This is easier said than done. And I'll come back to that in just a moment as I'm concluding. But before that, let's return again to our case one more time. So Dr. S recognized that the situation with this demanding patient is non-sustainable. It's negatively affecting Dr. S's well-being. It's taking away their time from other patients, and it's impairing their ability to care for this particular patient. Dr. S finds several local surgeons, one at their own practice and two at other practices. All of these individuals are willing to accept the patient. But Dr. S is still a little bit nervous. They're nervous how to broach the subject, nervous how to go about this, nervous exactly what they should say. So Dr. S talks things through with a trusted colleague, a little bit of play acting to figure out the best way of going about this, but then compassionately but resolutely tells the patient that they'll be transferring the patient's care to another surgeon. As I mentioned, I've spoken about this topic before, including this past June at the annual meeting of the American Society for Clinical Oncology, the big national oncology meeting. Interestingly, the theme for that meeting was partnering with patients, the cornerstone of cancer care and research. A few people at that meeting asked when they, after we had talked about this, whether the idea of setting boundaries and saying no might actually conflict with this idea, that of partnering with patients. Can you really say no, or put up a bar or a boundary to a patient while still be partnering with them? I would posit that absolutely we can, but it's complicated. But thoughtfully and carefully done, setting boundaries not only can ethically allow us to give more and potentially to partner more with our patients, it can also support our well-being, our sense of purpose, and our job satisfaction. Another important acknowledgement is that I don't claim to always be practicing what I preach here. I'm guessing that even those of you who agree with this idea probably don't all the time either. Setting boundaries and saying no is a lot easier said than done. It's really hard. But hopefully, as we're trying to think about this more, we can be more intentional about how we go about this and about saying no and setting boundaries for ourselves, for our trainees, and for others. So as good old Yoda would say, as I say do, as I do, do not. So do as I say, not as I do. All right, in conclusion, so conceptualizations of boundaries certainly have evolved over time, but they're not something that is new either in surgery or more generally in healthcare. Setting boundaries not only can be ethically acceptable, but they may actually be ethically preferable, assuming that we set these boundaries thoughtfully and assuming we set them carefully. And the flip side of things, if we have no boundaries, this can actually be quite ethically and clinically problematic, both for ourselves and for our patients. And finally, ethical boundary setting requires introspection, it requires intentionality, and it requires recognizing that there will be inevitable trade-offs. There will be some things that we will lose if we set boundaries and we say no. But it does sometimes require saying no to FOSNO or fear of saying no. Thank you again all for your attention, and thank you again to Dr. Hanto and to the Center for Bioethics and the Surgical Ethics Working Group for inviting me to chat with you all today. Thank you. All right. Take a quick sip of water, and then I will move on to invite and introduce our final speaker tonight, who is Dr. Louise King. Dr. King is a minimally invasive gynecologic surgeon and bioethicist. She has numerous leadership roles, but among them, in addition to her clinical practice in gynecologic surgery, she's director of research in minimally invasive gynecologic surgery, and also the associate program director of the minimally invasive gynecological surgery fellowship at Brigham and Women's Hospital here in Boston. Dr. King also is director of reproductive bioethics here at the Center for Bioethics, and an assistant professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School. Dr. King is training in both in medicine and law, having received her MD at UT Southwestern and her JD at Tulane Law School. Her area of focus in bioethics focuses explicitly on questions of informed consent, informed decision-making, and assisted reproduction, as well as equitable access to advanced gynecologic surgery and reproductive health care. She'll be speaking with us today on the impact of the Dobbs decision on the patient-physician relationship.
Thank you so much. I'm so excited to be here with all of you and with my colleagues on the panel. I've really enjoyed the talks so far, and I'll be trying to reference back to them as I speak to you now. I've also been noticing some incredible questions coming up in the chat, so I'm so looking forward to our conversation after my talk. Disclosures, I have no financial disclosures for you. I would like to disclose that I am going to talk about abortion, and I do provide abortion care. It's not the primary aspect of my personal clinical work. I'm primarily a surgeon, but sometimes I do get called in for the more complex procedural aspects of abortion care. But I am not as much on the front lines as others are in this fraught area of clinical care at the moment. I'd like to also highlight that in all of the other talks, there's been an underlying assumption that When we speak to and engage with our patients and our colleagues, we have free, unfettered ability to discuss all options, to speak freely about those options, to proceed along with the standard of care. And what I'll propose to you now, and I'm sure you know this to be true, is that after the Dobbs decision and with the institution and enforcement of restrictive laws in specific states within the United States, that is no longer possible in many states. So to borrow Dr. Elmore's case, I hope she won't mind too much. A patient who was 19 weeks pregnant with an advanced cancer diagnosis in some states, and most notably, I'll highlight the state of Texas, will no longer have the option of discussing the possibility of termination and focusing on treatment of her cancer. The physicians in question, clinicians in question, all members of our team will be essentially barred from even raising that possibility. That's a very different situation than almost all other aspects of clinical care in the United States. So I'd like to talk to you about how we got there, what I think underlies some of the reasons we've gotten to that state in this country, what it means from an ethics standpoint, specific to our communications with our patients, and where I think we might go from here. I was asked this past year to participate in a conference hosted by Radcliffe, and it was called The End of Roe, and I was actually part of the planning committee for that conference. As I struggled to create the slides for this talk, I eventually opted not to use any slides, as you can see. I realized that all I wished to say here, I had put together in that year-long process of planning for that conference and had delivered, but to a very different audience, an audience of lawyers and historians and philosophers. I've adapted the comments that I made at Radcliffe conference to give to you here because I think they are so relevant. As I noted, we organized that conference for clinicians, lawyers, sociologists, historians, philosophers, and members of the public. I was part of the planning group, as I mentioned, and we started working on planning that conference, The End of Roe, way ahead of when the Dobbs decision came down, as we knew that decision was coming. Anybody working in this field knew it was coming. Radcliffe asked each of us to pick one word to encapsulate our thoughts and feelings around the ramifications of the Dobbs decision and the restrictive laws that came into force. And I'm going to assume for this talk that you have a general idea of the legal and political history behind the Dobbs decision. I'll sprinkle some detail in, but I'm of course happy to answer clarifying questions at the end. The first words that came to mind for me as I prepared my Radcliffe talk and still are vivid in my mind of the dire clinical consequences of Dobbs are death, suffering, injustice, oppression, pain, some pretty vivid stuff. And the image I had in my mind was of patients that I see in my clinic being sort of battered within this circle of policymakers and societal expectations and stigma, and just almost being battered into submission. Specific to the question you presented me today about communication, I imagine patients and clinicians both sort of muzzled in a clinical room, not able even to talk to each other. You could say maybe my imagery is too dramatic. I propose it's actually quite accurate. I still hadn't arrived at that one word that the organizers really wanted. And in this conference, the word was going to be huge and right behind my head, and it was. And the word I came to, and that I would propose to you today that underlies everything that's going on here is the word trust. A loss of trust, a need to regain trust. And that was what was behind me and what I'd like you to keep in mind as I go through my comments here with you. I have certainly lost trust. I'm a lawyer. I was a constitutional lawyer in Louisiana and in California before I went to medical school. I had a deep sense of trust for our judiciary and our democratic systems and our legislatures. I've lost all trust in some of our judiciary and in some of our legislators, as I see them to have put aside intellectual honesty to achieve their goal of overturning Roe. They can only have achieved that goal because of the vagaries of our electoral system and disproportionate control that they wield. One need only consider what would happen in elections if the citizens of the District of Columbia and Puerto Rico were actually given representation. This would not be a question ahead of us, in front of us at the moment. So conservatives in this country have intentionally weaponized abortion as a political wedge issue since the 1980s. And in doing so, they've very intentionally worked to undermine trust in medical science and trust in expertise. Specifically, our Supreme Court and some legislators have in recent decades ignored the expertise offered by epidemiologists, sociologists, historians, medical professionals when they legislate and rule on abortion questions. One early glaring example of this was the ruling in Gonzalez versus Carhart, which was a case in which the Supreme Court essentially substituted Congress's assessment of what is medically necessary while creating the nonsensical term partial birth abortion. So they made illegal a procedure that is objectively safer based on what they believed was medically necessary in contravention of the medical expertise that was presented. I was in my first year of obstetrics and gynecology residency in Texas when that decision was rendered. And I knew then that we were starting down the difficult road to where we are now. And many who were following the courts knew that that's where we were heading with that decision in particular, because it introduced the ability of the legislator to declare that scientific uncertainty exists in areas in which experts see no uncertainty. And we now are also seeing this type of proclamation of scientific uncertainty weaponized in gender affirming care as well. In the Dobbs decision, Justice Alito begins his opinion by ignoring what I see as well-established sociologic survey data. He purports that abortion presents a profound moral issue on which Americans hold sharply conflicting views. But there's clear, reliable data that supports that 80% of Americans feel that abortion should be allowed under some but not all circumstances, and a full 60% would allow abortion without restriction. While we can't agree, at least in these surveys, and perhaps ever, about exactly what lines to draw, Americans do agree that abortion is essential medical care. There is no such sharply conflicting views among our citizenry. And they're correct on that point. It is essential medical care. Americans on the whole trust clinicians, and they also trust patients. They trust them together, their fellow citizens, to make nuanced decisions in these very complex settings around reproduction. They trust us to weigh all these risks and benefits to the best of our abilities. Again, hardly a state of a majority with sharply conflicting views. The Dobbs ruling goes on to hold that, at least from the perspective of a clinician, a pregnant person no longer has a right to protect themselves from bodily harm. This is based on a bizarre notion that a central document to our democracy, our Constitution, should be read so strictly so as not to extend a right to bodily autonomy to pregnant persons. Corporations, under the law and under decisions from our Supreme Court, are people, and they deserve constitutional protections, but pregnant persons no longer do. Current legislation restricts delivery of essential medical care to any person who is pregnant, and thus makes me question my status. It makes me question the status of my daughters and of my patients. As an aside, I spent the day at a conference on polygenic embryo screening and how we should push forward to make all of this new technology available in support of reproductive autonomy and choice. The messaging in that conference was so in favor of people having the ability to control these decisions about themselves and future children, to select among a variety of embryos, and by the way, to discard the ones they do not select, in stark contrast to the conversation we're having now about being stifled and unable to have full and open conversations with our patients about the risks and benefits of proceeding forward in different directions in their healthcare. I need to note that the risks of morbidity and mortality associated with pregnancy are very high. They're not simply relatively high to other risks, they are truly high. There are extreme additional burdens of morbidity and mortality for persons of color in this country. Most maternal deaths are preventable. Our failures to achieve the clinical care necessary to prevent those deaths is near criminal. We must do better. Yet I want to caution you as a clinician, many maternal deaths are not preventable. They're also unpredictable. And we add to this the large proportion of morbidity in obstetrics is not only not preventable, but has significant consequences. So taking on the risks of pregnancy will always involve risk. We will never obviate that completely. It is and should be a profound undertaking. Pregnancy remains a dangerous proposition, and simply by virtue of the biologic processes in play, it will always be dangerous. Unlike Justice Alito, I don't believe that the developing embryos or fetuses are persons. This statement comports with my own religious views. I'm Jewish, but more importantly, it comports with my understanding of science, biology, embryology, and neurology. That said, I deeply value the opinions of others. So I listen carefully to my students, my colleagues, and anyone who wants to tell me that I'm wrong on this point, and I listen to their point of view. I disagree. I accept their views for the purposes of discussion. So accepting that view, even if I accept that an embryo is a person deserving of the same protections as a pregnant person, based on my clinical knowledge, I would still not put an embryo or fetus's interests above those of the pregnant person in front of me in need of care. I wouldn't prioritize the embryo as a person over sharing clear and concise and accurate information about medical risk and medical options with the pregnant person in front of me. As noted, the complication rates in pregnancy and delivery are much higher than many other risks that we undertake in medicine. They're higher, for example, than if I were to donate blood or even a kidney or a part of my liver to my own child. Yet we typically all agree that I can't be forced to donate any of those things, blood, liver, kidney, against my will. I can't even be forced to donate after my death to either family members or other members of the community. Even though I would be dead, I still can't be forced to donate any organ. Maternal morbidity and mortality in this country is noted as exceptionally embarrassing high, in part because we do not provide our citizens with preventable health care. And thus they begin their pregnancies with underlying medical conditions. And this, along with many other factors, contributes to these high rates. So with the Dobbs decision in place and the laws in force in restrictive states, we not only fail to provide appropriate preventative care for our pregnant patients, but we also force them to undertake excessive risk. We do this only for pregnant persons. There are a few other ways in which our society imposes such high burdens discriminatorily. My legal colleagues at this conference at Radcliffe and others in the media have posited that under restrictive laws currently in place, we could interpret to save the life, which is the language used in some of these laws broadly, and that most quote unquote necessary abortion care could continue. But this simply isn't true. And we've seen that in the recent legal cases brought in Texas, where plaintiffs described being denied necessary abortion care in the setting of premature rupture of membranes and lethal fetal anomalies under that state's restrictive laws. Again, as I've mentioned, notably in Texas, under law, clinicians could not even discuss options with these patients until they were in dire need of interventions, and many of them left the state before that occurred. In states with restrictive laws, clinicians can no longer offer the standard of care to a pregnant person presenting with cancer, as mentioned, referencing Dr. Elmore's case. Cancers detected during pregnancy can be completely asymptomatic, but are still actively progressing. Thus, they don't meet the life-threatening in the moment kind of language that is in most of these restrictive laws. In the standard of care, abortion is typically offered, but it would not be legal under restrictive laws, and it's not life-saving in that moment. Clinicians cannot raise the option nor refer. Similar issues arise for patients with poorly controlled cardiovascular or pulmonary disease who are currently stable, or for patients with pre-existing conditions who require teratogenic medications for control. Potentially any pregnant patient, actually, who is otherwise healthy will run the risk of an amniotic fluid embolism. For example, I'd mentioned that maternal mortality is unpredictable. It's a rare but typically fatal condition, and we simply can't predict when it might happen. So every pregnant person is at risk in restrictive states, and every clinician is severely limited in their ability to communicate with their patients. Pregnant persons who seek abortion or who don't seek abortion may or may not be thinking of these general risks, but clinicians are thinking about them, and our ethical duty compels us to discuss them. Being stifled and muted in this scenario is deeply morally distressing. I must ensure as a clinician, if my patients wish to proceed forward to undertake the risks of a pregnancy and taking that pregnancy to term, that they do so voluntarily and with full information. And I can only assure that if safe access to abortion is readily available as an option that I can freely discuss. I can only achieve truly informed consent for my patients if I'm free to fully discuss these medical practices, risks, and options. I trust my patients to make the right decision for themselves, and I believe the American public trusts them as well. But they can, again, only make these choices about their reproduction if they have access to necessary care and the ability to learn about it. Medical professionals agree with overwhelming majorities that abortion is essential health care, that a pregnant person's right to bodily autonomy is an essential component to respect and delivery of that health care. Science supports this, whether it's the social sciences, biology, medical sciences. Americans devote a significant amount of money and resources to train their doctors and scientists, yet their legislators and justices ignore almost completely the evidence that we gather through that investment. This is not to say that Americans universally trust doctors. Our history of abuse in research and the rates of obstetrical trauma in this country are such that trust is certainly lacking here as well. And Dr. Elmore described this for you in her talk. Yet doctors and scientists are routinely listed as some of those most trusted by the people, and legislators are typically not as high on that list. Legislators and the judiciary must proceed with intellectual honesty and trust medical professionals and scientists who've developed a large body of methodologically sound evidence in support of abortion as essential medical care. I see that as the way forward. The Supreme Court and legislatures, when they create these laws or reference them in cases and make decisions, rarely, if ever, refer to this body of scientific evidence and as it relates to reproductive justice. This, despite our Congress frequently passing resolutions that note the importance of evidence-based legislation in other areas of legislating. And if you do a quick review of any of the restrictive laws passed, including the preambles specifically, it will highlight the data cited, which has no basis in science. There's quite a bit of it. An example would be it frequently highlights that they propose the suicide risk is increased with access to abortion, but in fact, our data shows that exactly the opposite is true. Many of you will know the story of abortion rights in Ireland and how Ireland's experience of women dying and their higher rates of maternal mortality in the face of restrictive laws led them to a way forward. They responded to these deaths with an amendment to their constitution. They brought forward the voices of the majority of their citizens that favored abortion access and reproductive justice, and they relied upon the expertise of the majority of scientists and medical professionals that they had trained and employed. We must do the same, but we can only do this if conservative legislators and justices listen to this evidence, experience, and opinion and to their citizenry. If they do not, we will continue to see reproductive issues weaponized for political and likely financial gain while stifling the ethical delivery of healthcare and the ethical communication that we wish to have with our patients. I welcome your questions. I'm so looking forward. I see they're been building up. Thank you so much for your time and attention.
Thank you so much, Dr. King. We have now some time for questions and discussion. So if all of our speakers tonight could take them, show their videos and come back on screen so that everybody can see you. We now have, we're slated to end at 8:15, but we can go a little bit over that, but not too much over. To start things off, a common theme across all of the different sessions tonight was trust. And so we talked a little bit about trust and fidelity in Dr. White's talk. Dr. Elmore certainly was referring to trust and distrust or mistrust as it relates to disparities and lack of diversity or inclusivity. It was certainly something that came up briefly in mine, and Dr. King expressed it quite directly in hers. Is trust in the clinician-patient relationship, and specifically in the surgeon-patient relationship, something that we only can aspire to, or do we have concrete things that we can do in order to improve trust in what many might argue is a quite broken system?
I'd be happy to comment on that. I think that you raised like a very good question, as there are, as we know, systemic racism is an issue, right? And there are significant challenges from the healthcare system level, from societal level. How do we, on an individual level, overcome those barriers and establish that trust with patients? And I think a large point in establishing trust is empathy, right? And so I think bringing empathy into relationships, understanding your own biases and how that impacts relationships, acknowledging what you don't know. And I think, doing these things can facilitate trust even within a broken system. And I think it's, optimistic for us to think we're going to be perfect, but, saying what we don't know, saying when we fail and acknowledge that, I think is a critical component to kind of establishing this level of trust with patients, even within the broken system that we know exists and that we know requires a lot of work.
Any
So
other
John,
from other
yeah, thanks, John, Richard. I completely agree with that empathy is important. I mean, I think trust really is the cornerstone to a surgeon-patient relationship. They come to you, you offer them advice, they entrust themselves to you as the surgeon to provide good advice, to do an operation, to do it safely and well, and to get them through that process. Well, not always the case. Many times, certainly in an elective practice, the patient has the opportunity to go elsewhere. They don't have to go with you. If they don't trust you, they can go somewhere else. Sometimes it's financially difficult for them to do it. And in certain situations, particularly emergencies, you don't have the opportunity to build up that trust. But in the majority of situations involving a surgeon and a patient, trust is, I think, the cornerstone of things. And that's how you can get essentially buy-in for the patient to entrust themselves to your surgical care.
And I think piggybacking off of your comment, I think it's holding space for patients' fears and anxieties and exploring that. I think so often, in surgery, we're like, this is the problem, this is how we fix it. And we expect, we're going to deliver that information and patients are going to accept it and be okay with it. But I think, as much as we can explore patients' fears, anxieties, and take that time, I think that is critical in establishing that level of trust with patients.
Yeah, I think our challenge sometimes as a surgeon is to sort of figure out what the patient wants from us, in addition to us doing the operation well, obviously. Are they looking for advice? Are they looking for counsel? Are they looking for just the facts, as in one of those models? Or are they looking for us to tell them what to do? That paternalistic or telling them what to do model certainly isn't as common now as it was in the past, but still sometimes you get a patient and they go, "Doc, just do what you think you need to do," and that's it. I don't know if that's a function of education level or society or where they are in society or whatever. And some, obviously, as you talked about, don't necessarily trust what you do or what you're saying. But I still think that of all the elements, that's the most important. They are entrusting their bodies to you to do something that could be a life-threatening thing. And you have to have both the physician and patient have to buy into that.
Okay, we lost Dr. Marin's video, but I understand he's back on audio. So, John, would you like to continue, or do you want me to pinch hit while?
Absolutely, yeah. No, I'll apologies. I'm not sure exactly what just happened there. For Dr. Elmore, building off of a question in the chat, I wonder if you could speak to a little bit of what you conceptualize in what inclusivity could look like. It was really interesting to hear you building off of the idea of diversity not being the goal, but rather sort of a step in the process.
Well, that's a big question, because I think, none of us have really seen or conceptualized what inclusivity looks like, because as you mentioned and kind of alluded to earlier, we do all work within a broken system. And so, I think the key for inclusivity is, and I think it's also addressing a question someone asked at the end about, is DEI in healthcare being attacked in today's climate? And I think it's not, right? So a lot of our diversity, equity, inclusion initiatives are a checkbox, right? I think Leslie Dawson and Justin Demick, who were out of Michigan and developed a cultural complications curriculum, put it best, but we have to attack cultural errors with the same attention that we attack medical errors, right? So inclusivity looks like no longer giving someone a pass for saying something flagrantly racist, right? Inclusivity looks like believing Black people, to be honest, right? Like when someone says, like, I'm hurting and no one's listening to me, believing them. And so, you know, it's moving a step beyond saying we want this, having trainings and checking a box, and actually living the action, which we're not doing right now.
Spectacular, thank you. Lots of additional great questions in the Q&A. To Dr. King, would be interested in taking a step back, not just from the issue of abortion, but to other, we'll say, politically sensitive aspects of healthcare, and wonder what advice you might have for those in the audience who raise questions about whether these are even issues that we should be talking about in a forum like this.
So in terms of in a forum like this, John, do you mean in an ethics forum, or?
I think both in an ethics forum and in the clinical space, sure. If you have different answers to those, that would be interesting.
So, I mean, the reason that certain issues become political, at least in the United States, is that they become topics that are galvanizing and that are identified in very very specific manner. You can follow the history of this back to the 1980s, and there's been a number of historians who've tracked it for abortion because that's the most prominent one. But when we politicize these issues around a particular delivery of healthcare or of health or one of the like in our particular system, it's for political gain, to gain influence. And then in our political system, it results typically in also financial gain. So I would propose that if you're very interested in changing that so that the discussion becomes not politically motivated to get people into office and to have influence in a variety of ways, that you think about how to remove those topics from our politic, because it's one thing to have wonderful, open, honest, probing discussions as citizens and concerned patients and stakeholders and the like. It's another to have these issues be driven by political motivations that are unrelated to the healthcare being delivered. Campaign finance reform would help with that. Addressing gerrymandering would help with that, et cetera, et cetera. From the perspective of medical societies and bioethics societies, and how we might better influence these conversations, and coming to the table to explain why these topics really need to be topics that we engage with in an intellectually honest way and not in a politically motivated way, and why that is important, not only for the delivery of the healthcare itself, but for how we approach these topics, I think is how we could create influence.
Great, thank you. There were a couple of questions with regard to the idea of firing a patient that I can address. A few people raised questions about whether there is another word for that. And as I alluded to briefly during my session, firing a patient certainly is, at the very least, a glib term, if not a outwardly disrespectful and far from ideal one. I would go so far as to say it's not something that we should even use ideally when we're talking to one another, but it is the most common term that is utilized either in the workrooms in a hospital or clinic, and sometimes even directly or in relation to and in conversations with patients. That said, I think it's wildly problematic. So whether we talk about discharging from someone's service or transferring their care, since ultimately that is in most cases, the ethical response to a situation in which you are considering quote unquote firing, it is transferring them to the care of another clinician. That would be a preferable term. I'm curious if any of the other panelists have any terminology or phrases that they happen to like better than firing a patient. I was seeing some comments that people certainly are not fans of that term either.
Yeah, I've never used that term but I've been in this situation innumerable times, and I typically don't fire people. I did see a question in the chat about how that affects other members of my team, which really made me think, because we have a lot of, and I'm going to massive air quotes here, difficult patients in my surgical clinic, where we deal with a lot with pelvic pain, which results in patients being really frustrated and angry, and they do take that out on our teams at times, and they're less likely to take it out on me than my team. And I'm really hesitant to ever turn someone away, because they've so often been turned away by so many other people, other clinicians. And so at the end of the day, I'm left with keeping them in the practice, but I realize that poses quite a burden on the other members of my team. And so I thought that question was deeply insightful. But typically I think about ways in which I could better partner with the patient to get them to a better place. And I try my best to involve my team in all those discussions moving forward.
I love that. Yeah. And I think importantly, I would argue that transferring the patient is, in the absence of abandonment, again, is the low bar. And that is not to say that it is the ethically optimal option in the vast, or even the clinically optimal option in most of these situations. I love the way that Dr. King just described that as different ways of working around that. And there's a pretty robust literature about ways to navigate complex relationships, while recognizing that just as many difficult patients as there are probably many more difficult clinicians. And so we probably need to turn that lens back on ourselves and acknowledge that it's a two-way street. Another question before I move to a couple of our other speakers was that with regard to how states and governing bodies can or should deal with patient abandonment. And I think the fact is that there certainly have been malpractice cases or clinicians who have had negative ramifications at their institutions, their hospitals or clinics or what have you, for not going about this in an appropriate fashion. There is certainly a literature in the legal space about malpractice suits for inappropriate transferring and what would amount to patient abandonment. Coming back to a common theme across each of these talks, as we are now at 8:30, and I want to have another question or two before we close. We talked a bit about the trust question, but what do each of our panelists see as both needs currently and kind of needs as we look forward to the future in the patient-surgeon relationship, both with regard to some of these issues we talked about today, or what are the things that people see on the horizon?
So John, it's Richard. Let me take a crack at that. I think one of the issues that's come up is the increasing availability of a large amount of information to patients, whether it's on Google searches or on the internet in other ways. They can come into your office and see you with a lot more information than was ever historically possible. So the physician has to sort of help them balance the information they come in with. They may come in with preconceptions that may be wrong or they may be right. And one has to take the time to assess that. I think one of the other things that we're seeing, or I've seen over the past several years here at BI Deaconess, is the access patients have to their own medical records, which historically used to be somewhat difficult to get. They'd have to go to medical records and have things printed up and go home get a bill for Xeroxing or something. Now it's just available online. Our progress notes, our clinic notes, everything is available to the patients immediately online, which is great. Sometimes it's problematic in that they can get results that have not been sort of even seen by the physician sometimes. They can see their path reports, their radiology reports, which we may not have even seen, and immediately they can call and want more information. So it does put added stresses, I think, on the situation. And many times the docs aren't withholding information. They just have to process it in their own time. And for the patient, It's obviously the foremost thing in their mind, what their CAT scan showed, what their pathology showed, or something like that. But for the doc, they may have multiple patients. They may have a clinic of 20 people, and everybody wants to know their results. And sometimes you have to prioritize things. So I think that does put some added stresses on the physician-patient relationship. This immediate access to all types of information, whether it's relevant to the patient or not, how does the physician or surgeon prioritize that in communicating with the patients? It definitely raises issues.
Thanks, Dr. White. Any of our other speakers tonight have thoughts on the forward-looking questions or concerns they have with regard to the patient-surgeon relationship?
I just wanted to jump onto Dr. White's comments because I agree that the open notes issue is a tough one, and we're recently creating guidance at the Brigham from our ethics committee on it. We've had open notes for such a long time now, at least in this community, that that we've sort of gotten used to it. And I found that being communicative ahead of time with patients about that and maybe warning them not to look at things until we can talk, it can be really, really helpful, preparing them for that opportunity of knowledge that maybe they should, do whatever works best for them, but that I would be available, but maybe not immediately when they read it, is kind of helpful. I really love the open notes, but I've also had to really change the way I write my own notes and be very cognizant of how I'm delivering information in that space. And I've also found really helpful with open notes is to write my notes with my patients. So now it's becoming a collaborative effort on our part to best document our interaction and our plan. And that change was really helpful to me. It's also made it much easier for me to get my notes done, but it was just a wonderful way to engage with patients in a new and different way. I suppose to some degree, all of these challenges that we see present opportunities for growth in that way.
Thanks, Dr. King. That's spectacular. I mean, I think it's important that we acknowledge as we're thinking about this, that many of these things that we're talking about, both as strategies here and in other parts of the session tonight, one, they're not easy, and two, they oftentimes require a change in practice and an investment of time. May ultimately, hope in some of these cases, save time in the long run, but this intentionality is important. As we close, any final comments or reflections from any of our panelists for tonight? Thank you again so much for joining us.
I think I'd like to end things with a parting quote from MLK, Martin Luther King Jr., actually. And it's one of my favorite quotes, and it's: "History will have to record that the greatest tragedy of this period of social transition was not the strident clamor of bad people, but the appalling silence of the good people." And so I think so often we see everything that's going on around us and say nothing because we're afraid of stepping in the wrong way. And so, in terms of, diversity, making change, moving forward in healthcare, I'd encourage you to have the difficult conversations and, use your voice to promote change.
I'm not sure any of us can follow that, so I will hand the baton back to Dr. Hanto.
Dr. Elmore, yes. Thank you very much for those closing remarks. I feel like we should end it on that note, but let me just once again thank our moderator tonight, Dr. Marin, and our presenters, Dr. White, Dr. Elmore, and Dr. King. I'd also like to thank all of you who listened tonight and asked questions of our panel. It was a pleasure to see the number of thoughtful questions that were asked in the Q&A. I think Dr. Marin was able to cover most, but I'm sure that we were not able to cover every single question. And for that, we do wish we had more time. I would also like to thank Dr. Robert Trug, who's the immediate past director of the Center for Bioethics, for his support, and Dr. Rebecca Brendel, the incoming director of the Center for Bioethics, for her continued unfailing support of the Surgical Ethics Working Group and this conference. Finally, I would like to thank Ali Stidham, Melissa Nosel, and Kyle Amato for their technical, graphic, and organizational support of the conference. On behalf of the Surgical Ethics Working Group, we thank you for attending. We hope that you've enjoyed and learned from tonight's presentations. And we hope that there is information that you will be able to use as you address bioethical issues in the future. Certainly, your questions gave the panelists and us food for thought. We look forward to seeing you back again next week. Good night.